Hey everyone, Dr. Pat and I would personally like to invite you to join us in our Grow My Baby program. This is week-by-week pregnancy and birth information developed from our experience of helping more than 4,000 women grow and birth their babies. All our links are on our website, growmybaby.com.au.
The information in this podcast is provided for education and research information only. It is not a substitute for professional health advice.
If you're trying to get pregnant or you are pregnant and you feel a little bit overwhelmed by all you need to know, then this is the right podcast for you. Welcome to the show. I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney. And this is The Kick, your expert-led podcast that delivers the essentials of growing a baby. Make sure you head to our website, growmybaby.com.au, to get some awesome free tools like our pregnancy knowledge checker to help you feel like you got this.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
Welcome to The Kick, and it's a Q&A, Patty.
Oh, good.
Good. I like a Q&A, and we've got quite a few, and I've been a bit indulgent this time. We've got a couple of just thank yous. Is that bad?
We had one of those last time.
Yes.
It is nice. It's lovely to hear from people.
Yes, and also one's a follow-up thank you to a question that we answered. So I think that's important too. So, all right. Shall we just get into it?
Get into it.
All right. Here's our first caller.
Hey, Dr. Pat and Brigid. Firstly, thank you so much for a great podcast. It was one of my main sources of information for my first pregnancy, and I love how you provide access to research and reliable information when there's so much conflicting and confusing stuff out there. I'm currently 9 weeks pregnant with my second bub, and when I gave birth to my first child, I got told I had a really abnormal looking placenta and umbilical cord. Unfortunately, a photo never got taken, but they described it to me as my umbilical cord branching out into tree roots and then attaching to my placenta. After having listened to your podcast episode on umbilical cord attachments, I'm wondering whether I had a velamentous cord insertion. Bub was fine and it didn't cause any complications for my labour. However, I was wondering, firstly, what are the chances of this happening again for my second pregnancy? And is this something I should raise with my midwife to make sure it isn't the case, as it was never picked up in my 20-week scan for my first pregnancy and wasn't documented on any paperwork? I don't want to be an over-worried parent, but I do want to do the best thing by myself and by my baby so we can both have a safe birth. Thanks so much.
Wow.
Great. What a great speak pipe.
Yeah. God, so people are so I wonder if people write their questions before they – I'd just be a bumbling mess. I'd have to do it about 10 times. But it's so beautifully put together, that question.
It's excellent, and it raises a number of issues. Firstly, it does sound like a velamentous cord insertion, doesn't it? But the cord,
I don't know. Yes.
The cord's going along, and then suddenly the cord kind of breaks up into vessels that come out like a tree roots, exactly like a tree roots, and then hitting the placenta, rather than the more common situation where it's just a cord right up until it hits the placenta. So it certainly sounds like that, and it sounds like that's what they were trying to describe at the time of that first birth. Recurrence of a velamentous cord insertion, I'm not sure if anyone really knows whether that's something that runs in individuals or whether it's a whole new risk each time. I'm not aware of the answer to that. But I guess it doesn't really matter, because a quality second trimester ultrasound is going to find that if it's there. So in this pregnancy, we're 9 weeks already. It's too early to say until 20 weeks. But at 20 weeks, I would recommend a scan's done. And ideally, if someone's had a previous, I won't say abnormality, I'll say variation in placenta or cord anatomy, then it'd be really good if the 20-week scan on this occasion was done at a really high-quality women's imaging centre where they're looking at placentas all day. You know, the things we do frequently we just get really good at. Yeah. Yeah. So I think that'd be really great if they could get a high quality scan, and it's either there or it's not. If the velamentous cord insertion is there, then the question becomes, what do we do about that? Well, we can't do anything about it, but it can be worse paying particularly close attention to third trimester growth, and occasionally even doing a third trimester growth scan if the placenta or the cord have unusual anatomy.
She mentioned that it's undocumented in her first birth, but it was a comment after birth by the midwife. Is she able, as the patient, to say it was said that it could have been a velamentous cord insertion? Yeah. Okay, so that's enough for the patient themselves to speak up and say, I need more.
It's a simple matter of when the second trimester ultrasound to be done between 18 weeks, when that's requested, that whoever requests puts on the piece of paper, velamentous cord insertion last time, careful attention to placental anatomy, please, and then they'll report it.
And if this person is going through the public system, do most public systems have someone that would be, in your opinion, the right person to do this type of scan?
Yeah, here in Australia, yes. That would be something that you would expect, that the person taking the ultrasound images and reporting them would report on variations of placental anatomy these days. Yeah.
Good. All right. There you go. Good luck, 9 weeks. That's very exciting. And good luck, and tell us how you go towards the end of your pregnancy.
Perfect. Good luck.
All right, we're going on to caller number 2.
Hi, Dr. Pat. Hi, Brigid. Absolutely love your podcast. I call it from the UK here. I have a question. We are 2 very healthy people. I am 35 and my husband is 39. I fell pregnant straight away after a removal of a Mirena IUD this autumn. Then I had a miscarriage discovered at about 8 weeks. Turned out the baby had stopped growing at around 6 weeks. I then had a D&C procedure, which was considered uneventful according to the notes. After 3 weeks, I took a pregnancy test as instructed. It was positive. I was then told to give it another week. I had another positive. I'm now waiting to hear back from the early pregnancy unit about the next steps. So I guess my question to you is, why is this happening? Am I likely to need another D&C? I'm worried about the added risk of multiple ones. And will this put us back in trying to conceive again? We're very keen. Thank you so much. And again, love your podcast. Thank you so much.
Another terrific question.
Can I say one thing?
That we're big in the UK.
Oh, I love that. People in the UK love us. That's great.
I love that. I fully expect if we ever go to the UK that we'll be met by like a marching band or something at the airport.
That will not happen.
Fully expect that because these really lovely people contact us from the UK.
Maybe because our health system is similar. I won't say the same, but similar.
But you think the marching band's not?
No.
Wow.
But what I wanted to talk about was just medical terminology. Was for the medical practitioner uneventful? Like, did you think she emphasised that they said the procedure was uneventful?
Yeah,
Yeah.
I guess when you look, that's a good point actually. When you, what I say to my junior burgers, that's the junior doctors who work under my supervision. I call them junior burgers. What I say to my junior burgers is you should not write something on an operating note that you wouldn't be happy for the patient to read or another doctor to read or, God forbid, a legal person to read in the event of a poor outcome. So I think that's good advice because back in the day people would write uncharitable things on operating notes and it's not a document where that sort of thing's appropriate. Uneventful, I don't know whether that's uncharitable or not. What that means to us is that everything went fine. Yeah. And I wouldn't want the patient to construe that as meaning that there was anything wrong. It means the opposite.
Yeah. Oh, no, I just think it was very eventful for her.
Oh, the whole of course it was. Yeah. The whole process was very eventful for her. And I think I can see what you mean, and I think that's the doc of the day who was on for the NHS hospital on the day saying I did another miscarriage and it was uneventful. Yeah. Eventful's bad.
Yes, that's right. No, I get it. I get it. And medical terminology is there for a particular reason. Right? Yeah.
But the process for the patient of having a miscarriage, it's upsetting for several weeks and rememberable for your entire life.
Yeah.
Yeah.
And now for this caller, it's continuing. So,
yes. Yeah. Now that's an unusual situation where the pregnancy test remains positive, and there's a couple of potential explanations. The first one, of course, is that the curette was incomplete. So there's a little bit of what's called trophoblastic tissue, which is sort of primitive placental tissue still in there, still in the uterus, that's still making a little bit of pregnancy hormone, and typically that's been disrupted enough by the curette to fade off with time. Yeah, so that trophoblastic tissue will eventually shrivel up and come out, and the hormone levels will go back to zero. Secondly, the second possibility is that somebody's already pregnant again, which is possible. May or may not be possible in this case, but it is possible for someone to have, a curette on one day, ovulate 2 weeks later, show a positive pregnancy test 7 or 8, 9 days after that, and by the time that they think to check again, it's actually a new pregnancy. And the third and rarest possibility is something called a heterotopic pregnancy, where there's a twin pregnancy where one's in the uterus and one's an ectopic in the tube.
Right.
And in some cases, heterotopic pregnancies are diagnosed when the miscarriage is in the uterus is dealt with, but the tubal pregnancy continues.
Wow.
Yeah. Rare stuff, but it's possible.
I've forgotten. Can you see a ectopic pregnancy via ultrasound?
Yeah, well, you would be able to see it this far in.
Yeah, right.
Because let's say the heterotopic pregnancy, they started off on the same day. By the time we know that that the miscarriage has occurred and the curette's been done, you'd be 7 weeks down the track, so you'd be able to see it. So, the investigations that this patient would be having would be an expert ultrasound to make sure the tubes look good and make sure the uterus at least looks empty, and then some serial quantitative beta-HCG. So not just the yes/no you get from a pregnancy test, but then a number from a blood test, and making sure that they're coming down.
And it sounded like she's concerned about having another D&C. Is there a problem with having D&Cs in a row?
Yeah, there is. Let's say, for argument's sake, it doesn't go away, and the pregnancy test remains positive, and it stays positive for weeks. Then the options are to continue waiting for it to come down. It's hard to wait forever, especially in someone who wants to be pregnant again. Or you can use a second curette. But when we do multiple curettes, in particular, multiple curettes in a row, we run the risk of causing abnormal scarring within the uterus, and a condition called Asherman syndrome, where if your uterus is very, very inflamed and scarred on the inside, then then on the inside of the uterine cavity, the front can stick to the back,
right,
and kind of obliterate the cavity, and then you can't get pregnant again. So we have to be very cautious about multiple curettes, especially multiple in a row, that we're not making a problem worse. And the third option is to use methotrexate, which is a drug that attacks rapidly dividing cells. It works a bit like chemotherapy for cancer. And if you give a dose of methotrexate, it can get rid of any remaining trophoblastic tissue, and then the pregnancy hormone go back to normal.
Yeah, wow. Gosh.
So there's plenty of options.
Yeah.
In this relatively unusual situation where a curette doesn't seem to fix the problem. Yeah.
You're listening to The Kick with Dr. Pat and Brigid.
How many times have you Googled something about your pregnancy?
When I was pregnant all the time, Dr. Pat.
Yeah, we get it. You may be confused or overwhelmed. It's normal to want information, but where's the reliable stuff from experts?
Yeah. Now, if you like our podcast, Dr. Pat and I have developed an online program to help guide you through whatever stage of pregnancy you're at.
It's taken us literally 2 years to put it together.
2 long, hard years, wasn't it?
But, it is a game changer in how pregnancy information is given.
Now, how it works is you get to sign up at whatever stage of pregnancy you're at. So you could be pre-pregnant, in your very early stages of pregnancy, late pregnancy, preparing for birth, or maybe you've just brought your baby home. And you get lots of information around that. And then you also get to join our closed Facebook group.
We've called in all our contacts too. So we've got a dietitian, anaesthetist, physiotherapist.
Sonographer.
Yeah, who else? Paediatric nurse, obstetrician, mother of 4.
Oh, just all the people you need to hear from.
So if that's you, come and join us at www.growmybaby.com.au.
Oh, good luck, UK caller. I hope that it all resolves very fast for you and you can get back on track. How long do you think she would be advised to wait after that curette to then start trying again?
Oh, I don't. Well, once the pregnancy hormone level comes back to zero.
Sorry, that's what I meant.
Yeah, by any of those various means, waiting, operating, or methotrexate, then if the pathology test from the curette showed a routine miscarriage, then it's not a medical decision about when to get pregnancy again. It's an emotional one.
Yeah.
So you get pregnant when you feel like you're ready to give a new pregnancy your complete attention. Yeah. Yeah. And in some people that's a couple of weeks, and in some people that's a couple of years.
Yes.
But it's an emotional when am I ready question, not a physiological medical one.
Mm. Yeah. Well, I think we'll move on to the next one.
Hi, Brigid and Dr. Pat. I've been listening to your podcast. I'm only up to episode 47, so some of these questions might be answered later on. But I have a few questions. The first one I wanted to ask is there such thing as paternal assisted C-section? So I know you have mentioned a few times that the mother can be involved. I was wondering if the father can do the same thing. I feel like it would be easier for them, seeing as they would be free to stand up and move around. Another question, or maybe an idea for an episode on the podcast might be how to pick a private OB and also like the pricing structures. So I live in Sydney and there's a lot of choice, a lot of different obstetricians. So just thinking of how to find what might be best for you and how to make sure there's not surprises at the end in terms of fees. I have a friend who's pregnant at the moment and she's been talking about having her placenta made into pills. And when I asked her if there's any science behind that, she didn't know. So I was just wondering if that's something you can cover. And I also saw a video the other day of someone doing an ice bath while they're very, very pregnant. It was online. There's a video I saw and I was wondering, is that safe? There are a few questions just reading off the top of my head. Thanks.
Well, episode 47 listener, she got a few questions in then, didn't she?
That's unreal. But I don't think any of those are things we've particularly covered in episodes 48 through to 92.
No, but
so this is great.
I do want to say
you're writing them all down. Write them down.
Well, I did. And I also want to say we do in the Grow My Baby program. We have got how to choose your care provider.
Yeah, we put quite a bit of effort into that, didn't we? And we. The first time we did it just said come to Dr. Pat.
Yeah.
But the Sydney people probably less likely.
That's a bit less likely, yeah. No, so we go through private OB, public care, midwifery only, independent midwife, shared care
GP,
with GP. Because in Australia, I know we get lots of overseas listeners, so your system's going to be very different. But in Australia, it's so confusing. And it's so confusing because you do think that you've got private health insurance and so things should be covered, but you're still out of pocket a fair whack.
Out of pockets,
so, you've got to weigh up the costs and the benefits. And we obviously think as being private, having a private obstetric clinic, that it's better to come to a private obstetrician. But we've tried to write it from a very non-biased perspective.
To cover the pros and cons of various approaches, including cost.
Yeah.
If we're looking at to go directly to that one about choosing, it's a really interesting question. Let's say, for argument's sake, your preference, our Sydney caller, their preference is to have a private obstetrician for the reasons that we think private obstetrician is a good choice. She mentioned about cost and surprises. There shouldn't be a single surprise.
Yeah.
So one of our jobs in the private obstetrics field is to provide people with what's called informed financial consent. So it's our job, our responsibility to make sure people know what's going to cost.
And we take that to the absolute extreme at our clinic. So we talk about not only our costs, but the costs that you might receive from, say, your anaesthetist or paediatrician. We advise you on all of those things, an assistant if you had a cesarean and needed an assistant to attend. So
it's a reasonably arduous responsibility. We've got to provide all that information and we've got to do it properly. It has to be up to date, and so forth. And it's good because people know what it's going to cost. But one of the things that's kind of bad about it is that at the very start, we have to be mentioning things like if you need a Caesar, then you've got to pay the anaesthetist and you've got to pay the assistant.
Yeah, if you want an epidural, you have
and the
to
poor
pay.
old patient's 7 weeks pregnant with their first baby going, what? They're talking about Caesars. You know, it's terrible. But it's just the way the rules work. So people have to be informed about the costs, and you shouldn't get a single surprise. Sometimes people get a bit of a surprise when they see that their private health insurer will pay the entire cost of them going to the hospital, but certainly not the entire cost of the healthcare they receive when they're there.
Yeah.
So there may be a gap from an anaesthetist, and there'll certainly be a gap from the obstetrician.
Yeah.
Yeah. So how do you choose? The old-fashioned way people asked their GP, and their GP had a relationship with some local specialists, and the GP would make recommendations, and that's still a thing. But I think these days that might the influence of the GP over the decision might be changing a little bit in favour of word of mouth, which has always been important in women's health sphere, and for better or worse, socials and websites. Yeah. So if you honestly don't know, then you start looking for somebody whose philosophy seems to match your own.
Yeah. And I'm going to say that cost isn't always the indicator of value. And, there's some people that perhaps they're just so busy it doesn't matter what they charge. They just charge more and more and more.
There's 100% that happens. So
you don't get the value that you think that very expensive price tag might give you.
Yeah.
So, yes, I would definitely look at value, how many times you get to see that person, how long they spend each time with you, what other, like in our pregnancy antenatal package at the clinic, at the Ballarat Women's Clinic, we have put other things in there. So, and we find that that's good for that person because we're actually seeing that person as a whole person that's growing a baby. So, there's a physiotherapy antenatal screen.
Oh, yeah.
There's
that's right.
Yeah.
And a lactation consultant.
And a midwife, and they get the Grow My Baby program. And, so we see that as we're trying to help them along the way.
Yeah, and part of the overall value.
Yeah.
One of the problems in capital cities can be that the person who's the most expensive is probably the most expensive because they are the busiest. So they just keep increasing their out-of-pocket fees, and then unfortunately you might find that the person who costs the most has the least time to give you. Yeah. I'm sure that happens. But taking all of those things into consideration, the trick, of course, is to find somebody who is a good fit for you, a good match with you, and you can be very, very confident that somebody who's a private obstetrician in Australia is well trained and has expertise in obstetrics. The decision tends to come down to other things about how much that person's approach to the job fits in with your expectations.
Yeah, and I have talked to you about this before, but yes, you get a Medicare rebate from the first visit. But if you don't like that first visit with that person,
I'll go somewhere else.
Go somewhere else.
Yeah,
you won't get the Medicare rebate again, will you?
No, but that's a small price to pay. Yeah. You can only claim one first visit. It doesn't mean you're stuck with the person you're sent to.
Yeah.
Yeah.
So, you might try a couple out and just sort of see, well, was that a good first visit? Did I feel comfortable? Do I trust this person?
Yeah. Yep. Absolutely. Yeah, you're under no obligation to stay if it's not working out.
Yeah. Other than that, come into the program because we talk more about that. Yeah. Plus, we talk about the placental pill. We've got that in the program too.
Yeah, we do. That's a topic for another day.
Yeah.
I like the paternal assisted
Yes,
Caesar.
we don't. We've never talked about that. I don't even know. Is that a thing?
I don't know. I've never done one.
Yeah.
I don't know if it's a thing.
Does make sense though, doesn't it?
Well, sort of. I think
I vaguely remember seeing something on the socials.
Yeah. In my mind, one of the main reasons to offer maternal assisted Caesars, which I do, is the relatively common scenario where the woman realises that caesarean section is by far the most wise ways to have her baby in whatever the clinical situation is. but it's not the same as actually wanting to have a Caesar. And putting the maternal Caesar on the table, so to speak, in my mind, it is about sort of saying, well, there's some consolation.
You still can have some agency.
Yeah. You're having a Caesar that you don't really want, but you agree, potentially reluctantly, that it's the right way to go. But by bringing in that extra contact between mother and baby and being the first to hold that baby and literally extracting the baby from your own belly is part of restoring what we might have lost by not having a vaginal birth. And so I think because I see that as something that's very important, we're prepared to go to the extra effort of having it all done. And I just wonder whether it's so important or important enough to have a paternal assisted Caesar. Yeah, that's worth thinking about. I'm fascinated by that. I don't
it's
know.
Interesting, isn't it?
Yeah.
And I think, we've got the beautiful example of our niece and nephew that have now got a 1-year-old, and the dad has so much hands-on, so much. I just think generationally, we're starting to sound like old farts here.
We are. See, maybe for them,
that is. They see it as they're growing the baby together, even if the woman's the one carrying the child. It just depends on their value system as a couple as well.
If we offered it, we might have a real problem with volunteers.
You don't think men would want to do it, or partners would want to do it?
Look, I really don't know, but I think 100% it's expected. Dad's expected to be there.
Yeah.
And I know some dads who are farmers and engineers, people who want to know how things work.
Yeah.
They stand up and peer over the drapes and see what's going on.
Yeah.
But most don't.
Yeah.
Most are on hand-holding duty.
Yeah, and look a bit sort of green or white.
Exactly. And happy sitting up the head end.
Well, maybe this listener has a partner that might be different.
Exactly.
That's why she's asked the question. How interesting.
I'm intrigued.
Yeah, we'll do more on it. And let's see if this starts questions about whether you can have a paternal assisted caesarean in our own practice. That'd be fascinating.
Absolutely.
This is a thank you one.
Nice.
This is a second-time caller, long-time listener.
Hi, Dr. Pat. It's Morgan here. You actually answered my question on your 7th Q&A in regards to having a C-section with a prolapse. And I just really want to thank you for highlighting a couple of things, educating me on how an actual C-section happens. I really didn't know that you didn't cut through the core muscle, and I find that really fascinating. So thank you for highlighting that to me. It was a bit of a birth, I would say, and luckily my daughter, she's fine. She has a really big calcified hematoma on her head from being stuck, but that's there could be worse things. I'm okay other than the prolapse and postpartum anxiety relating to the birth, I think. But I just wanted to say thank you so much. You've helped me decide how I will have my next baby in August next year, as I have just gotten my first positive test this morning. So thank you so much. Keep doing the wonderful work you're doing.
Congratulations on being pregnant again. That's awesome.
I just want to remind you, so this caller called a little while ago and she had, with her first baby, a grade 2 tear, bladder prolapse, and she was asking for whether her second bub she should have vaginal or caesarean.
Yeah, I remember that, and it was a cracker of a question.
And she doesn't actually say how she's decided.
Yes, and I guess it doesn't matter really. For her,
she feels
informed
and decided,
which is the trick, isn't it? And it's her private business which way she's decided. But one of the things we were trying to do in response to her question back then was deconstruct it a little bit and say, well, what do we have to fear from vaginal birth versus caesarean section?
Yeah. And
one of the things that she mentioned is that she was under the impression beforehand that a caesarean section was necessarily a more destructive operation than it actually is.
Yeah.
This is one of the reasons why I like doing birth plans, because it's not only a good idea to have a plan for anything, but people put things on their birth plan that that demonstrate that they've misunderstood something sometimes. And it's a perfect opportunity to say, no, that doesn't mean what you think it means. It means this.
Yeah.
And they go, oh, well, that's different. We're going to change the plan. So it's a great educational opportunity.
Yeah.
Yeah.
And thanks for calling in. Tell us, that helped. That's really great.
I love it.
I said I had 2 thank yous. This is the second thank you. And then we don't have another question, so I'm going to play it.
Sweet.
Okay.
Hi, Dr. Pat and Brigid. I just wanted to say thank you for producing this podcast. I think it's a really great resource. I started listening to it after having a miscarriage, actually, about a year ago, and now I have a 3-week-old baby, so I fell pregnant very quickly after that. And I also moved states while I was pregnant, so it was a nice, consistent source of information that I could always tune into every week throughout my pregnancy, which was wonderful. And I wanted to say also it was great to be very educated on lots of different things that might happen around the birth. So I ended up having an episiotomy, an induction, and vacuum. Baby had to be vacuumed, which was after a 2-day labour, which was not probably something that I would wish upon other people, but and also a late diagnosis of preeclampsia as well thrown into the mix. But I guess one thing that it sort of helped me prepare for was that anything could happen, and sometimes it's best not to have lots of expectations and just, to have an understanding as to why these decisions need to be made during birth. So thank you very much for all the wonderful information that you give everybody, and I've been recommending this podcast to lots and lots of different people, so lots of prospective mums out there. So thank you.
Excellent.
How great.
How nice. That's dear to our heart, isn't it?
Yeah, I think that by saying that, I don't know, you do get a bit of a false sense of the perfect birth, the perfect pregnancy. And I know we bang on about it, but honestly, I'm sick of social media. I am.
Oh my God. Yeah,
I get onto our Insta feed because we follow a lot of other baby pages and a lot of other, people having babies and everything. And I just think, wow, yes, I can see how people might get disillusioned with a birth that doesn't go to plan.
Yeah.
Yeah.
But if wishing hard enough for the perfect birth was enough, we wouldn't need hospitals, midwives, obstetricians.
Yeah.
It's not like that, and wishing hard enough is not enough. We don't want to be the naysayers who say, oh, this might go wrong and that might go wrong and that might go wrong. And in fact, plenty of people have a first birth that happens vaginally without intervention or concerns or the need for anything much at all. The issue though is that plenty don't, and to get preeclampsia, at least 8%. It's not a small number, awful lot of babies. To have a instrumental birth for your first birth in Australia, somewhere around a third.
Yeah, yeah.
So that's way too common to not know anything about it.
Yeah. So here's a caller that can still look at her birth and say that she knew what was coming, so she felt better about the birth. I think I think we can impact on how people feel about the birth. I don't want to make a massive statement and say we can work on birth trauma, but I think if you know what's coming, it's my gut feel that it can help how you process that birth after.
I'm convinced that's true.
Yeah.
So it's very generous of people to get in touch with us. And
it's nice.
Because to a certain degree they're sharing that.
Yeah.
It's always nice for someone to say thank you. We helped you. That we helped you. That's terrific. But they're giving something as well of their own story.
Yeah. Good. Well, we'll just high five each other later. Woo. Yeah. Woo. All right, everyone. That's the end of this Q&A session. These are always fun. So if you want to add your question, you just go to the SpeakPipe. The links will be in the show notes on our website. I think maybe even we have it in our Instagram social, the bio. Get on and tell us. And as you can see, a lot of people say anon. So if you're a bit embarrassed about the question, hey, please don't be. But just fire away.
Yeah.
We love them.
We'd love to hear from you.
All right. Have a great week, everyone.
Thanks, everyone.
Bye.